We'll just give it another 2 to 3 minutes, Jaswant, because we've gone live now. We're just waiting for some people. So we'll just give it 2 or 3 minutes and then we'll be ready to start. And thank you. In a minute more.
Okay.
A very good evening, friends. We hope that all of you have been well and safe and in good cheer. On behalf of the National Initiative and Integrated Resource for Child Protection, Mental Health, and Psychosocial Care, located at the National Institute of Mental Health and Neurosciences, Bangalore, supported by the Ministry of Women and Child Development, Government of India. Welcome to this webinar series, the August Talks. This initiative, supported by the Ministry of Women and Child Development, came after substantial work that we had done in the community with the conviction that the landscape of the practice of child mental health extended beyond the clinic to all the spaces and that children occupy and inhabit. Through this project, we hope to work in 4 domains: care and protection, mental health and psychosocial care, education, and policy and law, thus working across the country with all service providers and stakeholders, which means education boards, state education boards, schools, teachers, the judiciary, legal services authority across the state, child welfare committees, juvenile justice boards, childcare institutions and their staff, national academies such as the Police Academy, the Administrative Academy in Missouri, Childline India Foundation, the health sector and the district mental health program, really focusing on child protection and related aspects of mental health and psychosocial care. As part of this initiative, we'd like to focus on current issues, and the pandemic and the events that have followed since March have impinged on all our lives, changing the entire way of the world and both our internal and external ecologies. It is with great pleasure that I invite Dr. Jaswant Guzder to join us today. Jaswant is a professor in McGill in the Department of Psychiatry and the Division of Child Psychiatry and the Division of Social and Transcultural Psychiatry. She has a background of psychoanalysis, of art therapy and supervision therein. But more importantly, she's been a consultant to indigenous health and works extensively in refugee centers with multicultural practices which have ranged across a lot of work that she has done in India and Mumbai, but also in other parts of the world, particularly in Jamaica, where she's worked with high-risk children and various teaching projects and really looking at the issue of cultural psychiatry and indigenous populations. As I was having a brief discussion with Jaswant, she mentioned something very interesting, and I'd like to start, Jaswant, from that point. You said that what the pandemic has done is, or at least what we hope it has done, is that it has brought social inequity more sharply to light than may have existed hitherto. And also that it's an important time for mental health professionals. It's an important time to be a mental health professionals because it really gives a platform for the essence and the spirit of psychotherapeutic practice. Could we start with you expanding on this idea for our listeners today as we navigate through the rest of what the crux of our discussion is, which is challenges of cultural consultations to youth protection services for children from minority communities, and your experience with South Asian communities, the Caribbean and the Middle East is something we will cover in terms of cultural consultations. But the whole issue of social inequity and the importance of being a mental health professional at this point of time, Jaswant, your starting thoughts and ideas.
Well, thank you for inviting me, first of all. And I don't know who all our listeners are, but I hope this will be an engaging discussion. I do think that COVID has been an extraordinary experience to watch and participate in, because it gave us a social pause. And in the social pause of COVID, we now understand how important it is to be aware of access to service, social inequalities, how inequities affect care and outcome. And this has never been so vividly evident to everyone as it has been now. We have a chance then to look at what are the ingredients of social inequity and social disadvantage. And America and Canada certainly have begun to look at the fact, number one, do you keep statistics on special needs communities and minorities in your country? Do you actually track how social factors might affect access to healthcare and outcome? So that when you look at the very high rates of death of Black babies as opposed to white babies, when they're cared for in certain kinds of institutions, or the very fact that most minorities are not accessing services, in which ways they're not accessing services, and how these are all decided by social institutions. It's the first time that I've ever seen the university begin to look at itself as an institution that has racial biases and social biases within it. So the way we train physicians, how we make relationships and don't include the physician and the therapist as part of the problem and as part of the illness, and the institutions in which we are working, which reinforce the very inequities that we say that we are so neutral and oblivious of as followers of Hippocrates. So I think it's a very important time of your institutions examining themselves, but also physicians in training have a chance to relook at how they've been trained and what does the training mean and what's wrong with the training.
That brings us to the second point of the issue, which is that it's an important time to be a mental health professional.
Mm-hmm.
You spoke about it from the perspective of healthcare, but within the sector of healthcare, mental health care itself, how do you see this as an important time to be a mental health professional, particularly from the perspective of the kind of anxieties and uncertainties that COVID has caused, with particular focus on children?
Well, I think on several levels. One is that there's an awareness of moral distress for the first time, in a very wide sense, that this isn't just about us, but a decision about collective awareness of how my actions affect somebody else. And that has created a very important tension, especially in North America, which is every man for himself and individual rights and what about my feelings, etc. This tension is very interesting because it's brought out the strengths in many collectivist societies, including the indigenous societies. It's brought out the inequities of how we access health. And our vulnerabilities in terms of, are there invisible strands of casteism that stretch out across North America, which are deeply embedded in the whole way the economy of America was developed, and our attitudes towards indigenous people, which we have to relook at, because if we don't own what the sources of social suffering are, and we don't listen to both sides of position, we will not get to solutions. And so when you talk about being a therapist, being able to listen and not interrupt and criticize someone with a different opinion from mine is one of the skills we learn when we do psychotherapy.
Right.
Yeah. Yeah. So it's...
On that note, if we look at contemporary child welfare laws and the cultures that govern it, and if you look at the kind of systems that you come from, what we've done so far, Jaswant, in our conversation is we've spoken about how COVID has brought the social inequities to very sharp focus. We've spoken about how listening in the context of the moral distress that this has caused really highlights the critical importance of mental health interventions. But from a systemic perspective, in terms of contemporary, child welfare systems and child welfare laws, and other opportunities that are available to actually provide services, how has this worked out in your experience, and what do you see as the challenges?
Well, one of the things that came out because of COVID is how we collect data and what we don't collect data on. Not only what we do collect data on, like Canada doesn't collect data on ethnic groups.
Mm-hmm.
And so we actually realized how biased collection of data is in terms of understanding populations. We also begin to see that there's a whole political and social aspect to many of the things that are happening. So Black Lives Matter exploded at this particular time when it was also very evident in America that disparities of health inequity have particularly affected the Black population.
Mm-hmm.
And in Canada, there was tremendous denial that we even have such issues. There always has been tremendous denial in Canada about racism. So this idea of re-looking at how we interact with minorities, COVID's gift is that it's, well, do you want to see it, number one? And if you do see it, what are the implications of taking responsibility for it? And do you as a society want to take responsibility for inequity? And so this is now a very more pressing question in the universities. For the first time in McGill, anyway, that I can ever remember, we're having discussions about racism within the medical faculty. Mm-hmm. For students and for what's it like to be a Black student, all our patients, how we train people. We've never had these discussions in my memory before. Neither was anybody particularly interested. I mean, you just had to survive prejudice. You don't complain about it and become defiant and get pathologized for it. We're now actually welcoming this discussion at very high levels. We have permission to speak to it. And that means we have to be far more aware of ourselves and of our own unconscious biases and of our own difficulty with upsetting the world that we had become accustomed to. So if you don't collect the data, there's no evidence. If there's no evidence, you don't take responsibility. And that was a huge issue with the Indigenous people through their whole history here.
When you speak of Indigenous people and the whole importance, therefore, of data and how that generates a context and a consciousness towards action, and your interest in transcultural work and Indigenous populations, and particularly those who are marginalized, and how this inequity and marginalization gets sharply accentuated during human crisis, whether it's armed conflict or humanitarian crisis or pandemics in the past or disasters that take place when circumscribed geographical locations or nations are affected. And what has happened with COVID is that it has impacted the whole world. But if you trace the history of the kind of realities that these kind of epochs in human history enforces on people's consciousness, and if you look at the kind of stories of resilience that come out of it in your own experience set, could you give us some examples of what some of these poignant stories are from which we can draw as we build on our own mental health and psychosocial care response to people in predicament, particularly children?
Well, for example, if we think about the Indigenous people now, the Indigenous people, at least here, have very low rates of COVID. And one of the reasons is because they have become very militant about protecting their own territories. And they decided that nobody was going to be allowed in the reserve lands, which reduced their risk for COVID. They isolated their elders because it's a culture that actually puts the elders at the top of the culture. There was a very touching story I heard about how the young people would go to the elders' home on the reserves and do drumming outside of their homes so that they would not feel so isolated. So there was an engagement across generations, that they had a tradition of looking after themselves, and they'd already been wiped out many, many times by epidemics. So there's a cultural and collective memory of what the colonization meant and what wasn't acknowledged. And they no longer trust the government to be humanistic in its understanding. There is absolutely no data on the response in terms of the government. They haven't kept any records of how they would measure a healthy response in the reserve lands or amongst Indigenous people. So nobody even has an idea. Even here, I've heard of hangings on the reserve with young adolescents and drugs and so on. And the Indigenous people tell me that they know that the drug dealers are coming on the reserve, and they call the authority, the police, and the police are saying, we don't want to come on the reserve, etc. So there are all these old politics, which are ongoing, systemic racism about the Indigenous people and how they interact with institutions, are much more evident. But the Indigenous people have kept very quiet, and we actually have very few referrals, because I'm the child psychiatrist on the unit in Southern Vancouver. We have very few referrals, and most of the referrals are related to depression and anxiety of the youth. But we don't know the rates of domestic violence and whether those are increased, and that's our worry, is domestic violence, it's child abuse, and it's neglect and social breakdown within the community in the reserves. But we also see a resilience. So it's not all negative. It's also about the resilience of communities and a memory in a community of how to historically bind together. So there are also very wonderful stories coming out of this resilience. And that's very different from the stories of urban people.
So as we move from the context of Indigenous communities to the particular context of youth, and the major essence of what I want to share with you to get into the meat of this discussion, the challenges of cultural consultations for youth protection services facing children. What are the challenges, and what is the kind of predicament as far as youth protection is concerned, that at a clinical and mental health practice level that you feel that the profession has to contend and deal with?
Well, one of the papers I shared with you was Cindy Blackstock's paper, which was a conversation about social work and the Indigenous people and the history of it in Canada, and the important role that psychiatry and mental health and social work played in actually contributing to the cultural genocide.
Could you take the audience through some substantive portions of that paper, because it's very critical?
Yes, it's written by an Indigenous social worker. So that's another issue, is when minorities actually are visible in teams. That is, they finally get an education and become lawyers and doctors and the professional who serves you. Some of these things begin to work themselves out, but in fact, very few Indigenous people. There's one child psychiatrist in the country who's Indigenous at the moment. So we're just beginning to have there's nobody on my team who's Indigenous for Indigenous health. So there's one is representation of the person who serves you and whether you can identify with them. But in in terms of the indigenous people, there was, as well as putting the people on reserve and all of the things that went with colonization and being wiped out by infection and so on, was the massive movement to residential schooling, which is that we think that your culture is primitive and we're going to help you out by making you good Christians.
Mm-hmm.
And we're going to take all your children and put them into residential schools. And in these schools, there was tremendous abuse and very high rates of death, which were never investigated by any child welfare service. In fact, the child welfare services colluded with this. And they also colluded with taking away, because their projection on indigenous people is that they are primitive and they are unable to look after their children and they are not like us. They're not like the white society.
Mm-hmm.
And this kind of negative projection on any minority, that you are not like us and you are incapable, but this was at a devastating level. And no youth protection, no social worker intervened and said, this is inhumane. This is against human rights. And until we introduce human rights and advocacy as
Right.
part of how we train social workers, and the collaboration between mental health and social work is intimate. We are the same thing.
Right.
We're instruments of the same project. And and if there's no dignity for the person who you serve, and you have one standard for your people and another standard for the others, this is the problem of alternity, that you cannot deal with diversity and not understand and own what is going on in your institution, that you are looking at a people in this kind of prejudiced way. And nobody suffered more from that than the indigenous people. When finally they said this was actually cultural genocide, we stole
Mm-hmm.
their children. We not only did we not adopt them out to indigenous families, we adopted them out to people who had no motivation whatsoever in preserving their indigenous identity. So it was cultural genocide actively done by the Canadian government. And who was colluding and who was the instrument of it? It was mental health. So mental health has to understand that racism and structural violence is a public health problem. And
Right.
COVID has given us that gift. Finally, mental health cannot remove itself from that responsibility. So that would be my sort of summary of what we learned.
There's a question coming up on chat related to this, Jaswant, that I'd like to put from you. The question is from Jyoti Shetty. And before I read her question to you, I'll also invite all you wonderful people out there in the audience that if there are issues that you'd like to raise, questions that you'd like to ask, experiences and perspectives that you want to share, context that you want to debate and challenge, please feel free to put them on chat, and we'd like to take as much as possible that. And the question, Jaswant, is related to what you just said, and you refer to it as cultural genocide. So Jyoti asks, is there a ghettoization of communities, especially communities, with COVID?
No, I wouldn't say so. I think that communities maybe have things in common, but what is more important is the institutions that are there to serve you. What has motivated you to seek access to those services, and what has motivated you to feel that you are alone if you are a minority person? Those are very important issues. Where do you feel welcome and safe to get service? And what are your preconceived ideas that are reinforced by COVID, saying that another person passing me on the street could be contaminating me, exacerbates the issues of racism and difference. So Chinese people, for example, are very often targeted here. So if you're Korean or you even look vaguely Chinese, my friends who are Chinese tell me that they're quite shocked at the response they get. So this isn't ghettoization. This is about racism and about social suffering. And And the more invisible form of that is institutions. That's why we talked about, are you collecting data? Do you even know who's vulnerable? Do you know which communities you ought to be going to? And how would you talk to communities when you have excluded them in these dialogues? So the importance of community engagement is a responsibility of mental health. And that's what you're doing with the youth protection rollout here, is you're looking at all the levels at which children are exposed and the opportunities of schools and parenting and attachment and how fundamental these are. And they are socio-political. So if the Youth Protection Service decides that to reflect the values of the society that it's in, which it cannot help but do, it had better examine itself. Mental health has to examine itself.
Right.
So this happened against the Muslims in Quebec. It was unbelievable how prejudiced the laws became against Muslims. And Muslim children would land up in placement. Black children are 25% of the placements in Montreal were from the Black community. They represent 1 to 2% of the population. And the same for Indigenous people. Their placements went up by 70% in the 60s because, and these are institutional ideas. So the more important things are the invisible things, the unspoken things, the unspoken prejudices, the assumptions of institutions, and the lack of self-examination about how we allow or promote safety, cultural safety in our work. I don't know if that's a kind of
It is, but as you were saying this, Jaswant, there are several responses coming in, and which gives us the opportunity to really expand on this thesis. One pertains to the intersectionalities of minority identity. You refer to certain. And a related that's from Media. A related question from Varadarajan Tyagarajan is, when we speak about indigenization and modernization, right? So the intersectionality of minority identity on the one hand, and the indigenous and the modern on the other, how do you see as the reconciliation of these two? They're not polarities, but these two phenomena, shall we say?
Well, I think that the lessons of history are that if you know your history, then you're much less likely to repeat. And repetition compulsion is unfortunately a pattern of psychological, even in collectives. So we also have to look at, when you think about intersectional theory, then where is the place of gender, and where is the place of social class, and where are all these pieces of how we're made as a social being, that we can no longer separate ourselves, our internal life, from our sense of community and connection. And so it's not that I am supporting traditional values versus modern values or anything like that, but rather that each person has to own some place of where their blind spots are, and how their prejudices can be deconstructed, and how we deconstruct those actively as a dynamic in a diverse society, because we are actually interacting with our patients. Your patients are also teaching you to be less siloed and less ghettoized. And this is very, very important, is we have an opportunity to learn from our patients. We have an opportunity to either stay in the silo of the institution or decide that we have something to do with communities. And so, here's the advantage of thinking when you allow immigrants into the country, are you going to put them in a ghetto on purpose? No, they're frightened of ghettos here. So they disperse the Syrians all over the country, so they have no one to turn to who speaks Arabic and can form an identity. We have terrible problems in Canada with this across the prairies. Unbelievable amounts of prejudice in this country. And the denial is unbelievable also. Not that, and we're a very privileged country. We are so privileged, and we have really, we have such wonderful opportunities, and yet we have these deeply embedded colonial attitudes. we can deny them if we wish, but we can't deny them in mental health.
Right. Actually, Dr. Debanjan does comment on something which resonates with what you're saying. He says that xenophobia and racism are major public health problems, and
Yes,
it's high time mental health professionals take an active role in advocacy. Hearing and seeing what's not heard and what's not said. And then, of course, he goes on to say that intersectionality and stigma have been phenomenal in causing minority stress, across the age range and across gender, only compounded by what COVID has done. And in that way, like you pointed out, Jaswant, COVID has been an eye opener for social inequity. It's opened our eyes towards what social inequity actually means.
Can we bear the discomfort of it? Can we bear the discomfort of owning it within ourselves first, within our institutions, within our training? And because that change has to happen by mental health looking also at decolonizing itself.
Talking of institutions, Jaswant, there's an issue that Lakshmi Prasanna is raising about experience with institutions, especially residential institutions, coming to some core issues now of youth, children institutions.
Yes.
And there are some related issues, whether it's institutions or whether it's homes. Ananya really raises the issue of what's happening to children and youth, their angst, their anger, their anxiety, their concern in homes and in institutions. And the related question that Shubhrangshu has raised is, therefore, with children and youth's emotional response in homes and in institutions, how does one delimit or define mental health? Is it constructed? Would it be constructed now as a cultural narrative, or how do you respond to this in therapeutic ways?
Well, I'm going to give you the example of Jamaica itself, because in Jamaica, the social workers are actually frightened to go into many of the communities that we work in, where there is high violence and there is tremendous post-slavery trauma. These are the very patients that I have in Montreal. The Caribbean takes this with them. But what we looked at was that when a generation of parents are very traumatized, they need to be held. So what they need for children in infancy and in attachment support, those kind of services are very different. And primary care deals with all of this load almost alone. And then the next opportunity you have in society is schools. And in Jamaica, we felt we could not reach the parents to change what was going on. Neither could we undo the violence and shooting in the street, which the children were all exposed to. What we could do is change the school. So if the schools have an attitude of authoritarianism and strapping and exclusion and defining children who are distressed as bad, rather than children who therefore are showing us that they have a special need, then we need to address changing the pedagogy. Then we're talking about Paulo Freire. Then we're talking about, deciding that a child is bad and should be excluded at a very young age, because we're talking grade 2, grade 3, completely out of control. If you don't look after a child at that age and they don't learn how to read and they don't learn how to socialize to allow themselves to be taught, you're in very big trouble, because that child is on a trajectory that is going to be very, very problematic and high risk. We wanted to interrupt it, and we decided the way to do that is to change the way teachers look at children who have problems. And not only that, not just problem children, but how they teach. Right. So that how is equity taught, displayed in a classroom? How do you include everybody? What is the methodology of education? If it's rote learning and rigidity and you're good and you're bad, if it's only about competition and not about development, if there's no chance to be creative and have a voice and agency, then have you failed these children? And we are suggesting that yes, you have, because you have an opportunity to give them something different. and you need to give it early. By the time adolescents come and they've had all more and more of these cumulative traumas and adversities, it's too late. You need to intervene at the level where there is a safe environment that you could change, and that's schools, and that's daycare, etc.
Would the same logic hold for institutions? Because there are a lot of comments and questions coming up from the audience on the whole issue of, Ashika, for example, raises the issue of institutionalization, the same thing that Lakshmi Prasanna spoke about, that um, children's experiences in institutions, and are there ways of systematically assessing capacities of institutions, capacities of parents, and at a time like this where child protection, youth protection is of paramount importance in people's minds. The kind of experiment that you did in Jamaica, how does that apply to institutions other than schools, where children sometimes, unfortunately, have to reside because they come into the child protection system?
I think that schools are a wonderful opportunity for mental health intervention. I think it's a missed opportunity. And we have to be far more caring about our teachers, because our teachers are not trained to be mental health people. But in fact, they're the very first people who get to diagnose a lot of difficulties. And so if we take care of our teachers and actually train them to think about what they're seeing and how to interpret it in a different way and what they bring to it, we have an opportunity for resilience building. So it's really about resilience promotion, and prevention is very unfashionable for governments. Government is not interested in investing in prevention because the payoff for this is a non-voting group, the children. They have no advocate. So the only advocate they're going to have is primary care and parents and us. So we're in a position to take responsibility for improving, to whatever extent we can, how you would identify risk. And so children who are abused and dissociating are never going to be referred because they're no trouble to anybody. The people who are going to be referred, and that in the child clinics, it's the people who are disruptive and agitated, the people who are acting out and enacting. It's not the people who are quietly submerged in a terrible other kinds of responses. But we can help teachers to recognize that. And we could involve teachers in a very different way, so that parents aren't called into school to be criticized. They're called into schools to be supported.
Right.
And who navigates you when you come into an emergency room and you're from a minority community? The idea of navigators in hospitals to help minorities or people who don't speak the same language as you. All of those things are advocacy tools which promote institutional change and how people use institutions and feel safe in them. I don't know if that sort of
It does. And moving from there to some core clinical contexts, Bhavika, for example, is bringing up the issue of how does this play out for children and adolescents with special needs? We have COVID, we have child protection issues, we have lacunae in systems, but how does this play out for those who are meta minorities or or special needs set? And what has been your experience, Jaswant?
First of all, I don't think we've ever had an experience like this of this extent of the pandemic. So I can't even begin to answer that very important question. But I will say that children with disabilities, with autism, with learning disabilities, and the people who I have in my practice now, we are really bewildered as to what the school boards are going to do for them. And first of all, many families who are poor don't have computers. They don't even have access to all this kind of fancy online access. And if you have a special need in autism, who is going to serve you? How? Because we're not going into people's homes anymore either. So we have to readapt and re-engineer how we think about the competence of parents, that is, and how we equip parents to be advocates, and how we advocate within the systems that we have to work with this. And I don't have a good answer for this. I think even when these children grow up, we have huge issues, because adults are autistic and disabled children are going to become disabled adults. And often there's no public policy covering their needs during COVID. I mean, I have an adult autistic brother who's in his 60s. He has there's no information from the ministry about providing him any special care. So there are all these kind of issues that have, again, COVID has unmasked them. So now we have the responsibility to create an answer. So I think the questions are more important as a beginning to the discourse of how institutions would collaborate.
Right.
To create something different.
So Pitobash Das asks, how do we address the mental health issues of children belonging to marginalized families residing in hard to reach or even unreachable areas? You know, you have great experience of working with indigenous populations. Some of them, live in, geographically isolated and difficult to reach areas. How do we navigate this issue?
It's a very huge issue.
Yeah.
Rural health is a huge issue, and we've had many webinars about this. And the other advantage of Zoom webinars and so on, I must say, this is the one advantage I've seen on answering this question, is it was possible to bring 300 people on rural medicine together on one Zoom and actually expose them to the questions of how are they innovating, how are they using cell phones, and how are they using technology, and how are they outreaching in rural areas, and their dilemmas, so that they could actually start to ask the government also to become involved and be sitting in the webinar. So one way is that you join together different levels of power, because this is about power sharing and collaboration. It's not all on the mental health worker, but on the institutions which are saying, oh, we didn't know you had a problem. We didn't know that there was an issue of marginalized communities. Unless we say, yes, there are special needs children. What about this? It's not going to change. So we have a huge responsibility in terms of articulating the discourse that the parents and the children are mirroring to us. And that's an evolving question.
Right. And Mala Saluja, in response to what you asked about schools and models for schools, I want to draw your attention to a program that Jaswant has been involved in with her friend Fred Hickling, who unfortunately passed away a while ago. And this is called Dream a World Project, based in Jamaica. It's a wonderful, school model, particularly for very vulnerable youth. That I've also put in a website here, which has a lot of material on the kind of work that you can do in schools. So please do go into this and do search the net for Jaswant Guzder and Fred Hickling on Dream a World project, which is a school model. Going ahead, Jaswant, there are many other issues and comments that people have raised. Mitali, for example, says that she agrees about intersectionality in causing and exacerbating minority stress. And it's all the more important for mental health professionals to reflect and acknowledge biases and prejudice when we treat people. And interestingly, a little before that, when Shubhranshu asked, does social power and position determine who is bad and who is incompetent? But he also followed that up with a very interesting comment where he says, we are made of the same clay that we are trying to mold people of. That, and the extent to which, and we recognize that. Puneet has raised a very interesting question, because that sets the tone going ahead. And his question essentially is, we are now in COVID. This may last for the rest of this year, perhaps spill over. What happens thereafter, Jaswant? Are you able to envisage, imagine, or foresee what's going to happen as far as child protection, youth protection is concerned, and mental health coming out of COVID?
Well, we've actually never experienced this kind of global experience in quite the way that it's happening at this time. I think that we have an opportunity for change, which is very unique. And I'm not so interested in predicting what it will look like, but I think it's very evident to us that we have to take responsibility for thinking about what we're seeing now. So if the tsunami has come and the temple is now unmasked, and you now see what it is, and you now see the social disadvantage that your system is actually engineered on, we have a chance now to advocate for change. We have a chance to educate ourselves. We have a chance to discuss how we are training people, and how we're involving communities, and how we are supporting the competence of parents, not to take away children, but to keep children in families. And then you come up against all the bureaucratic rules about why we're not going to support a child in a family, but put them in an institution, because then we have one budget, and those are the children that we're giving that budget to. But you can't have a very disturbed child in your family and have those resources, because we're not going to budget that, etc. So you now get into the politics of how money is allocated, and how the vision of policy is allocated. And this thinking should go on now, because this is now is the time. Actually, that's why I think these seminars are so important, is that now is the time for us to really consider what is the vision that is going to meet the needs of those who are often excluded and disadvantaged, and how are we going to address social suffering in a way that promotes the resilience and strength of our populations, not pathologizing people, but rather using what are their strengths, just like you do in family therapy. You don't look for everything negative about a family. You start by looking for everything positive about it that you're going to build on. So our vision of what is mental health is going to be on the line. And why is prevention so irrelevant to government? I mean, if it's so irrelevant to government, then we have to object. We as mental health workers have to say, you just missed an opportunity to change something that's going to cost you thousands of dollars of prison and everything else later on down the line, and terrible burden. And this is what we have the power to do that. I really think that we have to use our power in a different way.
It's interesting that you speak about the whole issue of prisons, because Sarita Vaz and Dr. Rajendra put two questions which are kind of related, and these are about children who come into conflict with the law, children from marginalized, vulnerable communities who are into substance abuse and so on. And this whole technology and the new normal that is there going to be inequity and a social divide here, and how do we sort of bridge and navigate it for those youth who come into child protection system who are vulnerable because of the background that they come from, but already are in conflict with the law or with externalizing behaviors and substance use and those kind of manifestations?
I think adolescence is very, very difficult work. I admire all the people who are doing work with youth and adolescents, because it's much harder than the younger age groups in terms of respecting the autonomy of the adolescents, and knowing that substance abuse and all these other agendas are well underway in that age group as self-soothing and solutions to their difficulties. We've taken a very forensic approach, a punishing approach to children with conduct issues. And I think it's not working. I think it's just it's so we have information that helps us to think, well, then what would work? Is it navigation? Is it mentoring? How do you adapt learning situations? What would you do with children who are, and this is a problem, we have a huge problem with this in Indigenous health because it's generational. The children who were taken away to residential schools are the parents and the grandparents of the kids I am now seeing. And they are saying that their entire life is scarred by what they call the Holocaust. For them, this was a genocide, and it has impaired the parenting for generations. But they have now some compassion for those generations, and there is really, many of them are soul destroyed. So if you think about Shengo's idea of soul destruction of children, soul destruction comes from this lineage. And we have a very big problem in mental health. We have to share this responsibility and our distress. I think we have to take what we hear in our listening capacity and take it in terms of its moral implications as well, in terms of what kind of advocacy we're going to decide to do. And we can't do everything, but different people in your group may have very different areas that they want to focus on, that they feel really have to be done. And it's not a short-term project. I mean, we're talking 15, 20, 25-year project, right? This is not quick and dirty.
Jaswant, last couple of questions in a quick response. Harshini's question is, child protection, abusive family institutionalization. How do you balance these?
It's a very good question because, first of all, who is defining the abuse? Okay, that's one thing, because that's a huge issue for minorities here. Is if you're not, your culture is different from my culture, but your culture is obviously primitive, and therefore we have to take your children away. This is a whole other area. But the not pathologizing is part of really doing a good evaluation of where are the issues. Are the issues generational? Does this family have any strength? Does this family engage with community? Do I really want to remove this child, or do I want to keep them in the family? But then the system won't pay me the supports that family is going to need to keep them there. They'll only pay me for the residential care. So now we have a political problem about money and about policy and about how governments see this as opposed to how people on the ground see this. So again, there's this opportunity for people in mental health and primary care, and much of it falls on general practitioners and people in primary care like nurses who have to be pragmatic. And we need to equip them and listen to them and say, what would you suggest in this community? You know, would you suggest a group of Sahelis who go and mother other mothers in the community? Like how do you get creative about supporting families at risk beside from taking away their children, which is a devastating solution. Unless somebody's a psychopathic, agitated parent, you want to support that child and you want to support that parent if you can, not by dissembling the family and rupturing everything. If you can, you'll do it but you see, this costs more money.
Yeah.
And so now you have to think very creatively. Well, then,
that kind of addresses the issue that Sahana Nag also raised, about the challenges of parenting.
Yes.
Jaswant Guzder, thank you very much for this engaging interaction. I must say that a lot of people, Devanjan, Shubhrangshu, have been speaking on the basis of what you said about the importance of narratives and reconstructing the social narrative of suffering that really helps in empowerment and of the marginalized and social recovery beyond pathologizing the problem. And Shubhrangshu raises a very important issue about what kind of approach works, and just for your information, Shubhrangshu, Jaswant had recently sent me an article which I found very engaging. This was a shift from trauma-informed care to healing-centered engagement. Because trauma-informed care is is very specific to trauma, whereas healing looks beyond that to the whole person. Trauma is only one thing that happened to the individual. It does not define his or her identity. And therefore, Shubhranshu, what you speak about, the whole issue of power narratives and actualization narratives, or what Devanjan calls as social narratives, that to really look at strength and resilience based approaches that work better. And in fact, Dream the World project with Fred Hickling, led in Jamaica with Jaswant's participation and deep involvement, is an example in a really vulnerable population where homicide and violence was so high. How they managed to, through art and through music, to really make a change. And that's the kind of approach that we really need to keep in mind if we want to change the social fabric and the realities of the children that we serve to assist. Thank you very much, ladies and gentlemen, for joining us in this very engaging webinar. Thank you very much, Jaswant, for your time. We know it's early morning where you are. It was wonderful to speak to you. On behalf of the National Initiative and Integrated Resource for Child Protection, Mental Health and Psychosocial Care, NIMHANS Bangalore, supported by the Ministry of Women and Child Development, Government of India. Ladies and gentlemen, take care of yourselves, keep good cheer, and let's work together to, as mental health professionals, to work on the kind of responsibilities and the very important context that we are in, where we can change the narrative of mental health practice by the kind of issues that Jaswant has raised. Good night. Take care. Thank you very much, Jaswant.
Thank you. Thank you so much for having me. Thank you.